Come on. We have the three pillars to advancing physical therapist imaging scope of practice. Dr. Lance Mabry is an assistant professor at High Point University, Doctor of Physical Therapy program, where he teaches diagnostic imaging and primary care. He received his doctorate in physical therapy from U.S. Army Baylor University and is board certified orthopedic specialist. Dr. Mabry's research focuses on clinical application of diagnostic imaging with a focus on expanding the scope of physical therapy practice by research-driven advocacy. And he's going to comment on what I believe to be a really critical piece of evidence in support of PT imaging. His observational study entitled Physical Therapists Are Routinely Performing the Requisite Skills to Directly Refer for Musculoskeletal Imaging. An observational study was just recently published by the Journal of Manual and Manipulative Medicine Therapy. And for a deeper dive, I also heavily recommend that you see and check out the link below for an excellent webcast in which Dr. Joe Tata goes in depth with Dr. Mabry, and they get deep into the substance of PT imaging referral. So I think this is a really critical interview as well, just to dig that much deeper into the substance of Dr. Mabry's efforts. So I'm going to stop the share, and you're up, Lance.
All right. Well, thank you so much for having me. It's going to be really difficult to follow Dr. Steiner and certainly Dr. Dauber. So thanks so much for everything you guys have done. So today I'm going to talk to you about the three pillars of PT imaging advocacy, which will essentially set up a framework to advance scope practice in your state. So one disclosure I need to put out front here is I do receive compensation for teaching continuing education, and continuing education as defined in our board rules is one of the three pillars that comes up here. So I'm not trying to sell you anything with this lecture today. So what are we going to go over? Well, I'm going to start off with the state of the states, which frankly, Dr. Steiner already did a great job with that. I'm then going to pivot to what the three pillars of imaging advocacy are, and that's going to be entry-level education, continuing education, and routine practice. And then lastly, we're going to close with our research, which was just mentioned, just published in the Journal of Manual and Manipulative Therapy. And we're going to talk about where imaging skills are being utilized by setting, by degree, by experience, by residency or fellowship training, by board certification, and lastly, by APTA status. So this was already mentioned a little bit, so I don't want to go into this too much in depth, but essentially we have various levels as far as where the states are with their imaging. So some of them, like Pennsylvania and Illinois with Dr. Aaron Kyle, are kind of leaning on the silence in the guidance to allow them to order imaging. There are many more states than this. These are just two examples. Then there are some that are looking more at board rulings or opinions or decisions. That was what Dr. Dauber just talked to us about with West Virginia. There are others that are more in the rule or policy phase. That's Colorado. And then the pinnacle of this, depending on how you look at it, is when it's ingrained in law. And those are the 5 states up top. Now, as we look at these, the higher you get up this chain, the more time, cost, and risk is involved. So to get legislation passed, usually you're talking around 8 years. By comparison, if you look at the timeline that Dr. Dauber just gave us, I think that was roughly a span of 6 months between his first inquiry. So as you go further up this chain, there's a lot more expenditures that come with this. However, one of the things that can be looked upon with this is as you get further up this chain, there is an increased level of security as well. I don't think anybody's concerned that Wisconsin's going to lose their ability to refer for x-rays or North Dakota. These are ingrained in law, and the chances of that changing are pretty low. However, the further we go down on this list, there are some more risks, right? And one of the risks with the silence approach is with being silent, you really can't talk about it a whole lot, because if the wrong people hear about it, things can be problematic. So if you would contact the average PT in Pennsylvania, most of them don't know that it's silent, and it's hard to really advertise that and get practice to change. But it can be really helpful in starting to collect data and see outcomes and start publishing stuff in that space to help establish that framework. As you start going further up, these, like with what Dr. Dauber just talked to us about in West Virginia, once it's written somewhere, it's really easy to send out to the masses. We can send that board opinion out from West Virginia out to the masses in West Virginia and actually get some movement as far as practice is concerned. However, there is some concern at this level. If a law is passed somewhere else, it can actually usurp what's going on here. So that's one of the things we saw with Wisconsin. Wisconsin at one point had a board rule that allowed physical therapists to refer for imaging. They were referring for x-rays, MRIs, and all sorts of imaging. Then a law passed that prevented radio techs from receiving those consults, and all of a sudden Wisconsin lost everything. Now, since then, they've gone up to legislation, but they never did regain the ability to refer for MRI. So there are pluses and minuses to where you fall on all of this. But as we look at what modalities for imaging are available, the further we go up this chain, the less likely we are to get these other modalities, or at least that's what history has shown us. So 4 of the 5 states are stuck at X-ray only, where as we go further down the chain and the board rules or the board opinions, all of those, every last one of them has been all modalities, which is exciting. The one exception is Utah as far as the legislation, and that's because it's not written in the PT Practice Act. It's actually written in the Radio Tech Practice Act that basically says that they can accept referrals from physical therapy, and it doesn't go further into depth as far as modalities. So all things to consider, and with that in mind, if you're going to lean forward and establish a board rule, you have to figure out how you're going to do that, whether that be the language like Dr. Dauber has talked to us about, or if you ask the question, you have to make sure that you're ready to give the evidence to kind of support what you're looking to ask about. So when we looked into this a little bit, it's a little overwhelming with how much research is out there as far as where to start and how to frame your question. And what we found in North Carolina is the definition of permitted practice, and essentially has these 3 items here. So permitted practice is that which is routinely taught in educational programs, continuing education programs, and routinely performed in physical therapy practice settings. Now, understand this is just North Carolina. It's not necessarily transposable to all states, but there's probably similar language that you guys can find either in your board rules or your practice acts as you go through. So using that, we can actually establish the 3 pillars as we're building our argument to be entry-level education, continuing education, and routine practice. So let's start off with entry-level education. So in 2014, Boysen et al. Published a study that found that 98% of DPT programs are teaching imaging. That was followed up in 2015 with something that Dr. Young talked about, the Imaging SIG educational guidance, which is currently being updated. And then in 2016, CAPTE actually included this in their guidelines for accreditation, that it's mandatory that DPT programs include diagnostic imaging in their entry-level education. Another thing that's interesting to think about with entry-level education is, okay, so this education is provided, but is there any standard by which it's assessed? Well, within the NPTE, they have 9 different systems, body systems that they test on. And within the biggest block of that education, the foundations for evaluation, differential diagnosis, and prognosis, in every single one of those 9 body systems, diagnostic imaging is required. So I have an example here from the cardiovascular and pulmonary systems, but is listed the exact same way in every single one of these systems. So in the biggest block of the NPTE, that's where diagnostic imaging falls. So certainly there has to be some level of imaging competence in order to become a licensed therapist. So what about continuing education? So Rundle et al. Put a study out last year looking into where people are getting their education from. So some of them are getting it from academic postgrads like DSC programs. Others are getting it from residencies or fellowships. Obviously, the traditional pathway, conferences, continuing education, self-study, things of that matter. So let's dig into that a little bit more. And this is one, as you're building your argument, can almost be Googled to support this. But the first thing I'm going to start you off with is that residency and fellowship track. So as we look at the description of residency practice, as we look at the description of fellowship practice, and as we look at the IFOMT educational guidelines, diagnostic imaging is a requirement for all of these. So if you're going to have a clinical residency or you're going to have a clinical fellowship, imaging is almost certainly going to be a part of this. So that's the front end, that's the requirements. What about the back end? Are people actually getting this? And Dr. Gerke is doing a great job on this. He has a couple of abstracts that are out. He's writing the manuscript now, and hopefully the publication will be soon. But he's actually looked at some residencies and some fellowships and actually found in the high 90s the percent that are actually receiving imaging education. So clearly residency and fellowship is a pathway forward for imaging. Obviously there is some more traditional continuing education out there. This top one is from the APTA Learning Center as instructed by Dr. Aaron Kyle. The one in the middle here from MedBridge is from Bob Boyles. And the bottom one from Redefined Health Education is a series of imaging courses that I teach. And those that enjoy self-study, you might want to check out this book, The Fundamentals of Musculoskeletal Imaging by Lynn McInnes. It's probably the best book out there from a physical therapist standpoint as far as imaging. And Dr. McInnes is truly an inspiration, wonderful person. So that brings us to that third pillar, the routine practice. And this gets a little bit more tricky. And the reason it gets tricky is because we are a republic. So contrary to what you hear in the news about us being a democracy, we've never been a democracy. We have always been a republic. And essentially what that means is what happens in one state is not necessarily of a concern for another state. So if we're trying to convince a board in, I'll say North Carolina or any other board or any other legislator, they're going to want to know what's happening in that particular state with their physical therapists. And while we can provide lots of information about it happening in the military, there's a lot of authors out there that we know about, the Crowell et al.'s, the Moore et al.'s, the Goss et al.'s, the list goes on there. In the States, Dr. Kyle is probably one of the leads in that space. Worldwide, there's a good article by Froment et al. As far as how imaging looks worldwide. But if we're going to set up an argument, if we're going to talk to a board or a legislator, we can include all those things, but we should also talk a little bit about our state specifically and what that looks like. So with that in mind, the idea behind our study that we were setting up is really trying to understand how we can show routine practice within a state, especially if that state explicitly prohibits the practice. It's kind of a catch-22. How do I show it's being practiced if you don't let me practice it? That's ultimately what we published in JMMT. Shout out to my co-authors. Thanks so much for your mentorship. And our concept behind this was that essentially physical therapists might not be pulling the trigger on doing the order itself, but we're essentially doing everything else. We're using evidence-based guidelines. We're determining when they need imaging. We're sending them maybe to an intermediary like a PCP and telling them what imaging they need. We're talking to them about the imaging and routing them accordingly, but we're just being prohibited from doing that administrative task of sending the order. But that's never really been proven anywhere. So the first thing we need to figure out is if we're trying to say, are we doing everything else? First thing we need to do is establish what that list was. So we got a pool of physical therapists together and we came up with this list of 9 skills, 5 of which would happen before the image was ordered and 4 of which are responsibilities that occur thereafter. And the idea behind this was the first step is triage the patient. If the patient's having a heart attack in your clinic, it's unlikely that you're going to order an image because they don't belong to you. The second step is if they do belong to you, are you using evidence-based guidelines from an imaging standpoint to determine if they need imaging? If you determine that they might need it, are you considering the risk versus benefit in this particular patient? Are you requesting imaging? Maybe you're not referring it, but maybe you are reaching out to a PCP or an intermediary. Maybe you're reaching out to orthopedics and you're asking for imaging, even if it's not directly to a radiologist. And if you are making that request, are you suggesting imaging modality? Are you saying you want radiographs? Or are you saying you want MRI? Or are you just leaving it up to that other provider? And then ultimately, at some point, the imaging order is placed, whether that's by you or somebody else. And then once that's done, there's some responsibilities on the back end. You need to review the report. You need to educate your patient on the findings. You need to integrate the findings into the plan, essentially correlate with what's going on. And then lastly, and this is an important piece from that safety standpoint, if something does come back that's outside of our scope, that we do make sure that we're referring the patient on appropriately. So once we establish that list, we sent it out via survey through Qualtrics. And great props to the APTA, the chapters, and AOMPT for the distribution. We got a huge response. Ultimately, we included roughly 4,800 in our study. Here are our demographics. What you'd essentially expect: a high proportion of orthopedics, which is pretty consistent with the practice. Higher proportion of DPTs, even though we have a pretty solid group of over 20 years old, or over 20 years of experience. So you can see that the DPT is really becoming dominant within the field. We also looked at residency and fellowship training. Majority did not have that. Majority were not board certified. We also wanted to look into those that were referring to a radiologist or military or federal to make sure they weren't being too much oversampled. In this case, military and federal were only 4% of our sample, which is good. And those that were referring to radiologists is actually higher than those that were military and federal. So that shows progress within the civilian sector as well. The one thing that should be of note is we had a higher proportion of APTA membership than what we normally see. I think APTA membership is 30% nationwide of PTs because of our distribution being primarily through the APTA, where we were oversampled there. So what ultimately shook out? So here are 9 skills. And you'll see that all 9 of these skills, the majority of physical therapists were practicing these skills routinely. Even skill 5, which was the lowest practiced, which was suggesting an imaging modality, was still practiced by the majority of PTs. And overall, the average physical therapist was practicing 7 of the 9 skills, which is a very high rate of imaging skill utilization. This is excellent for us. And in fact, 28.2% of those paneled actually reported performing all 9 of these skills routinely. This is important, and we're going to come back to this a little bit later as to why that is so important. So where does it fall in regards to settings? So if you look over here on the right, this is our total sample. As you can imagine, orthopedics and sports were significantly higher than the total sample as far as their utilization with imaging. I think we'd all kind of expect that. Similarly, acute care, home health, pediatrics, and rehab or SNF were all substantially below the average on imaging utilization. And I think that's probably not a surprise to anybody either. But once we established where imaging was being practiced, I wanted to circle back, and Dr. Dauber talked about this a little bit, but I wanted to talk about, the Wisconsin Practice Act and the West Virginia board opinions. They kind of gave guidelines as far as who should or who should not be allowed to order imaging. And some of the things that we're seeing in here is the DPT. The DPT is huge in our imaging advocacy. And those that say that DPT did nothing from the profession certainly aren't working in this advocacy space, because it is the very first thing that comes up every single time we talk to anybody from an advocacy standpoint. The other thing we see is this board certification, residency or fellowship. We're seeing these things again in West Virginia, the DPT, residency and fellowship. And that gave us a second set of questions is, okay, well, do these things matter? These things are being put into rules. Do these things actually matter in regard to imaging skill utilization? And what we found was, for the most part, yes. So we looked at BPTs versus MPTs versus DPTs. And as you would expect, because of the CAPT curricular changes, DPTs were using more imaging skills than their MPT and BPT counterparts. Now, imaging skill, we're not talking about imaging utilization. As I show people this, they think that means that DPTs are referring for more imaging. That's not what this is. That means they're using those 9 skills, like using evidence-based guidelines, triaging the patient, considering risk versus benefit, The DPTs are doing this more so than the NPTs and the BPTs. Right. And now one of the counters we tend to get with this when we talk about this is, well, what about experience? And what we actually found was a bit surprising. I was anticipating more of a linear response to imaging. But in fact, what we find is new grads actually experience some growth over time. But then over time, that kind of trails off as far as imaging skill utilization. So if we did a best fit line, experience is actually negatively predictive of imaging skill utilization. The more experience, the less likely, although you wouldn't want a linear model for this. So we're probably going to need to do some more secondary analysis to see what's going on. But experience in itself does not look like it's a super good factor when considering this. So residency, fellowship, and board certification, those also struck as being higher in imaging skill utilization. That makes sense when you think about the description of residency and fellowship practice. When you look at the board certification, this, just like the NPTE, there are tests of diagnostic imaging in there. And then the one thing that kind of shook out that we weren't expecting is that APTA members actually did more imaging skill utilization than those that weren't. That could be potentially an artifact from our distribution, or it could be just that APTA members are awesome. But that was not something we were expecting as we were going through the process. So ultimately, what can we take from all this? So each of the 9 skills that we discussed in this study were all performed routinely by the majority of respondents. The average respondent was using 7 of 9 skills, which shows a high level of imaging skill utilization in routine practice. And then the 28.2%. So the question is this a high number or is this a low number? 28.2% as far as using all 9 skills is an incredibly high number. And one thing I hear from the field is, we need to educate 100% of every single physical therapist to mastery on imaging before we move practice forward. And the reality is that's just never going to happen. Not 100% of physicians perform surgery, but yet surgery is allowed by the Practice Act. Not 100% of physical therapists performing dry needling, but yet it's allowed in most practice acts. Not 100% of physical therapists are doing spinal manipulation, but it's allowed in most practice acts. We don't need to achieve 100%, but showing that we have 28% that right now are performing all 9 skills demonstrates that very clearly this is being routinely practiced in the United States. We actually broke down these results by state and sent them privately to the states. We didn't want to publish that publicly, but all the states should have their data. If they don't, please reach out to me and I'm happy to give it to you. And ultimately, these findings support that, yes, in fact, when we build on the entry-level education, the continuing education, and add this piece of routine practice on end, all 3 pillars are supported, and this does support our ability to expand the jurisdictional scope of practice to include imaging referral. So just again, a review. So we talked about a state of the states, those in, having it in law versus board rules versus board policies, and what that impact that has on security or modality utilization. We established the 3 pillars of imaging advocacy framework. If you're going to pose an argument or have to present some research on this to someone, this might be a good way to do it. Entry-level education, continuing education, and routine practice. And then lastly, we closed with our study in JMMT, talking about imaging skill utilization by setting, degree, experience, residency and fellowship training, board cert, and APTA status. So thank you so much for that. And do we have any questions?
Let's open the floor up. Thank you, Lance. Dr. Mabry, what seminal work. This is the stuff we need, frankly, when we're advocating. I look at your Practice Act in North Carolina, and I just wonder if when they did craft the language, did they not realize they were handcuffing us? Whereas we have to show that we're using for instance, any sort of skill that we want to acquire, at least any new technology that we want to adapt to for diagnostic purposes. Did they not realize that this is a real handcuff statement to say, it's like, well, you have to prove you've used it already before you actually start using it. I mean, I just think it's an absurd, I just wonder what people are thinking when they crafted that language. That's my beef.
Yeah. So one, the good news is it's not in the Practice Act. It's actually the board rule level. And what I'll say is, one of the things I really learned is engaging with the state board. When I very first started off with this, I didn't know a lot, and I viewed it almost as as an adversarial relationship, like we're being prohibited from doing these things, and therefore there should be this friction and everything else. And
Right.
as I've gone through, that's actually not the case. I think that I think to a degree, without breaking any antitrust laws, I think we're all on the same team of trying to advance practice with safely for our patients. And the more I learned about it, the more I came to really appreciate the state board. And I think, the language that's out there a lot of times is just things that were written decades ago, that were probably the right things to write at the time. So decades ago, when these things were written, it was probably the right choice at the time. But now here we are in 2022, and it's probably time to update it.
And that would be nice. And what a nice collaborative attitude. I'm worried about words that calcify, frankly. What is next steps? Do you think the North Carolina board members are amenable? Are they craving news? Is there an appetite for this new evidence? And how are you going to approach it? Or you're not allowed saying?
Oh yeah, I don't know if I want to. I don't know if I want to dig into that a ton tonight. I
He
apologize.
never does. He never gives up the ghost on this.
Yeah. No, I mean, I think that my view was, there were some things that we were going to do. There were some things that we needed to investigate from a North Carolina standpoint. And in doing this study, we could have done it just for North Carolina, but frankly, it was not a whole lot of extra effort just to do it nationwide. And I think that was the idea, was just, well, if we're gonna do the lift, we might as well do the lift for the whole nation, and then states can use that as they deem appropriate. But I think that just like with what Dr. Dauber talked about, I think that the language we use and the way we ask the question is important. And because of that, I don't want to get too much into detail with North Carolina or any other state. I think that a lot of times it's potentially better to keep those things quiet until there's something to say.
Fair enough. Well, we wish you